الصوت مسموع كويس حضراتكم؟
ايوه يا دكتور علاء،
اوكي.
جاهزين يعني.
اتفضل دكتور عبد السلام.
And now we have Roche Symposium about Xyva in follicular lymphoma أو that could change the setting of the new line for treatment of Hodgkin of follicular lymphoma. Dr. Alaa Kandil, Professor of Clinical Oncology, Alexandria University.
شكرا يا دكتور عبد السلام. شكرا لحضراتكم. بسم الله الرحمن الرحيم. As already mentioned by Professor Abdel Salam, we're trying to set the new norm in the treatment of follicular lymphoma, choosing the optimal front line of follicular lymphoma management. So basically, what we have actually, these are the items of my presentation. So we'll start about where we stand in follicular lymphoma management. As you can see, there is a big difference between patients who have no early progression versus the patients who have early progression. And this data from the German Lymphoma Study Group or from the British Columbia Cancer Agency, you can see a huge difference between the patients who do not have early progression as the patients who do have early progression. And this is very consistent everywhere. So an early progression was defined at 24 months post-treatment, and you can identify the 5-year overall survival of 50%, for instance, with POD24, okay, progression at 24 months, or 90%. And the earlier the progression occurs, as mentioned, the higher the risk of death. So do we have something to tell us about the patient who will progress or recur early or not? Yes. It's very important to be able to identify those patients at high risk at diagnosis prior to treatment. You are exactly knowing your patient and prognostic criteria of your patient. And those patients might be candidates for either alternative treatment, which is the so-called risk-adapted therapies, which may include investigational regimens in clinical trials. Because if you know that at the beginning of the treatment, that's very valuable piece of information. So what do we have in hand in terms of prognostic tools? We have so many. We have the Flippy one, that's the earliest, M7 Flippy, Prima PI, Flex, and we'll try to go into them one by one. So the oldest ones are the Flippy and the Flippy 2. This is very simply a very useful prognostic tool. You can still use till now if you would like. And that includes factors like the age, hemoglobin level, the clinical stage of the disease, the level of LDH, and number of involved nodal sites. And you can see here on the right-hand side that if you have a high score, you would have something like a 50% survival as opposed to 91% with low prognostic score. So that actually was developed in the pre-rituximab era, but since then it has already also been validated after the use of MabThera or rituximab. And you can see that the landmark analysis of overall survival with and without progression at 24 is there with quite a difference between the two curves for the patients with low risk and the high risk patients. You can see a huge difference in there. I'll come to the Gallium trial in a minute. However, the Gallium trial is the main trial that got the approval of Gazyva, a new anti-CD20 treatment, exactly like MabThera, but with more potency. And you can see actually that the rate of POD24 by Flippy risk group in ARC chemotherapy, rituximab chemotherapy versus Gazyva chemotherapy, and you can see the difference here. 12% versus 21%. This is something like a 10% reduction by the use of Gazyva and applying the Flippy score to indicate the patients who are mostly of a high risk nature. But I'm sorry, the computer is somewhat slow. So the Flippy score is good, but still it's not as sensitive as we like. You look at the right side hand of the slide. These are the patients who did not progress. Some of them still have high Flippy score, 44%. So it's not as sensitive as we need, but it still is working. So that moved us to the Flippy 2 score with more clinical pathological factors, including the B2 microglobulin level. Again, it works. High score or high risk patients, 77%, and almost 98% for low risk patients, and in between 88% for the intermediate risk group. Okay, so data have shown that Flippy 2 is superior to Flippy 1 in predicting outcome. However, since then, most centers unfortunately do not routinely measure B2 microglobulin. I don't really know why, because I thought that was something like a basic thing, but reading through the center's experience, not everybody measures the B2 microglobulin, which is an element in determining the patients in the Flippy 2 risk categorization. Then we move to the M7 Flippy. M7 Flippy is more advanced because it does not only include the clinical pathological features, but includes the study of mutation status of 7 genes. This is actually what came up from the M7 Flippy, which is, you can see that the survival in the high-risk patients is almost 42% and exactly double in the low-risk patients. However, 7 gene mutation is not easy thing to do in every center. Not every center is qualified and prepared to do such a thing. However, it showed its significance, and it has a higher accuracy to predict the POD24. As you can see, these are the data, earlier data from the Flippy. As mentioned above, you still have in the low-risk patients, 45% have a high score. But now you come to the M7, that was reduced by half, 21%. So this is more sensitive test to apply to detect the patients at high versus low risk. Again, from 42 to 14%. But it needs a study of the mutations of 7 different genes. Okay? So the high-risk M7 Flippy was associated with shorter progression-free survival in patients treated with R-based regimens and patients treated with CHOP CVP-based regimens. Okay? Now we come to the POD24 PI, another prognostic tool. This is a simple modification of the M7 Flippy, which integrates Flippy and the mutation status of only 3 genes that increase the sensitivity to 78% and 61% in the 2 cohorts. So this is somewhat a modification and a combination of the M7 Flippy 1 plus only 3 genes, not the full 7 genes. And this is actually how it would differentiate patients. You have a 48% 5-year survival in the patients with high risk, as opposed to 89% in the patients with low risk. Now comes the most recent and updated and quite applicable in our practice, which is the FLEX. What's the FLEX? Is the Follicular Lymphoma Evaluation Index. It's based only on clinical variables, making our life quite easy. We don't need genetic analysis, okay? It's able to identify high-risk patients by predicting both progression-free survival, which is a key endpoint, and progression at 24 months, POD24, following first-line immunochemotherapy for follicular lymphoma. In the Gallium study, which is the landmark trial for approval of the Gazyva, FLEX was better than Flippy 1, Flippy 2, Prima P1 at discriminating between patients with a good or poor prognosis in terms of progression-free survival and overall survival. And you here see the factors included in the model of FLEX. You see the LDH, you see the B2 microglobulin, hemoglobin level, performance status, extranodal status, grade, and sex. And you see that actually with very good correlation, the FLEX is the highest. This is the gray as compared to the other tools in our hand, like the Flippy 1, Flippy 2, Prima PI. So actually FLEX showed superiority, More importantly, it does not only show superiority, as you can see on the left-hand side. This is actually the difference between the low-risk patients and the high-risk patients. It actually enlightens us about the type of chemotherapy we are applying. You see the low-risk and high-risk with different treatment types, using bendamustine, using CHOP, using CVP, and it still is working there. So Flex seems to be the answer as a prognostic tool in managing patients with follicular lymphoma. And it may be argued that poorly clinical prognostic scores are not optimal in the modern era of integrated clinical genomic methods. Our data in the Gallium trial was actually very sufficient and told us exactly that Flex is there to stay, and it's very applicable and very helpful. Now we come to the trial we're talking about today, about the new player. First, we have to consider what do we expect from treating a patient with follicular lymphoma, and what is the patient expecting? The patient expecting is overall survival and the time to next treatment and the quality of life. These are the most important factors as a human being or a patient would think about. How much will I be living؟ طبعا بعد امر ربنا اولا واخيرا. امتى هاخد علاج تاني؟ انا هبقى عايش ازاي؟ الكواليتي اوف لايف بتاعتي شكلها ايه؟ From our side as physicians, احنا usually we look at the overall survival, progression-free survival, and the rate of early progression. And we have to look more and more into quality of life exactly as the patient is looking at, because this is a very important issue for the patient we're treating. Now we come to the Gallium trial. This is a multi-center open-labeled randomized phase 3 trial comparing Gazyva plus chemotherapy versus MabThera plus chemotherapy. Okay. What's Gazyva, by the way? It has a difficult name, obinutuzumab. This is Gazyva. It's a glyco-engineered type 2 anti-CD20 monoclonal antibody, and it's already there to be used. It has a lower complement-dependent cytotoxic affinity than rituximab, but actually it has a greater antibody-dependent cellular cytotoxicity and phagocytosis and great direct B-cell killing effects. So it seems more efficacious. This is the trial design. You have more than 1,200 patients, or approximately 1,200 patients. In the first line, non-Hodgkin lymphoma follicular treated, stage 3 and 4, bulky disease if they are stage 2, more than 7 centimeters with good performance status. Patients are randomized to either receive Gazyva plus chemotherapy for 6 to 8 cycles, or rituximab plus chemotherapy 6 to 8 cycles, and then you give a maintenance of Gazyva in the upper arm or maintenance of rituximab in the lower arm for 2 years. And the data are really very strong. Superior progression versus progression-free survival versus MabThera, a 34% reduction in the risk of progression or death with a very high median progression-free survival. You look at the Prima study looking for rituximab or MabThera plus maintenance MabThera versus Gazyva versus maintenance. You have an extra 3 years with a hazard ratio of 0.66, meaning 34% improvement, as I just mentioned before, which is actually very meaningful to our patients and our practice. You have a 46% reduction in the risk of progression at 2 years, and that was observed. You can see that actually these are the 2-year cumulative instance in the rates of progression at 2 years. So collectively speaking, you have, when compared with bendamustine, you have a 37% reduction using Gazyva. With CHOP, I'm sorry, that was R-bendamustine. R-CHOP, you have 28% reduction with the use of Gazyva, and with RCVP, you have a 20% reduction. So it's very consistent against all other regimen when compared to Gazyva with chemotherapy. This benefit is seen there in all subgroup analysis. So it's a very consistent finding with a very acceptable toxicity profile. As you can see from the Gazyva and the MabThera use, there's really very mild difference between the toxicity, especially for grade 3 patients, more than 2% difference between treatment arms, naming neutropenia, thrombocytopenia, infections, and infusion-related reactions. So it's quite safe to be used and more efficacious. Now, for the second part, what about the patients who have already been treated with rituximab with their follicular lymphoma? So we have now the Gadoline. It's a phase 3 study in relapsing refractory follicular lymphoma. Those are patients with non-Hodgkin lymphoma who progressed during or up to 6 months after induction or maintenance therapy. This is about 400 patients now being randomized to Gazyva plus Benda versus bendamustine alone, looking at the response rate, complete response, partial and stable disease, and then again having a Gazyva maintenance in patients responding. And you see now a hazard ratio of 0.48, 52% reduction in the risk of disease progression or death. And those are patients who are treated beforehand with MabThera and chemotherapy. So those patients are still responding with the second line anti-CD20 Gazyva. Thought before that those patients are having very low chance of improving. However, we see in our phase now 52% reduction by the use of Gazyva. You see that also in terms of overall survival, 0.58, 42% reduction in the risk of death. Again, a very consistent finding, not only in terms of progression, but also in terms of decreased mortality. And this is actually the clinical benefit rate and the reduction of risk, 52% reduction in risk of progression or death, extra 29 or 30 months as per the investigator assessed median progression-free survival, and no safety concerns with the use of Gazyva. Now, this is something like a universal thing we would always think about treating a patient with follicular lymphoma. What are the surrogate markers that are being developed for early evaluation of response? Is the PET CT? Can we really know that from the evaluation after 2 to 3 cycles and then doing another PET, provided you have done an initial PET before the treatment, or the minimal residual disease, or the circulating DNA monitoring? So the gallium data suggests that at the end, with doing a PET with a minimal residual disease responses, these are very prognostic in determining the progression-free survival in first-line follicular lymphoma. As you see actually from that, adding PET to minimal residual disease, the risk of progression, disease, or death in patients achieving either very good response after treatment with residual disease negativity was 2.1-fold greater than in patients with CMR, the patients who did not really respond after treatment with Gazyva plus chemotherapy. So we're talking about early progression. It's very important to note that all patients receive the most effective first-line treatment. This is actually something that you face when deciding the treatment for patients. I mean, yes, we do think about that in our country because of financial constraints, but talking scientifically, you should start with the most effective treatment. And nowadays, we know that Gazyva plus chemotherapy is the most effective treatment. You should use the currently available prognostic tools, and you should use the surrogate markers, which are still in development. Nobody can say exactly that we are fully developed in identifying those patients. So again, just to emphasize the point of Gazyva in the first line follicular lymphoma treating patients, we have a 34% reduction in risk or progression. That extra 3 years with a median progression-free survival showing a hazard ratio of 0.66 and a 46% reduction of risk of early progression with a very acceptable toxicity profile. For all of the above, in the most recent version of the NCCN for 2020 for follicular lymphoma, you see actually that it's already been there, and with the other treatments, by the way, and we should always consider it in there for either the first line or patients relapsing after follicular lymphoma treated with MabThera plus chemotherapy. At that, I'd like to end. And thank you, and like to thank Roche for giving me the opportunity, and for our meeting to give me this opportunity to talk to you. And I'm happy to take some questions. Thank you very much.
Thank you, Dr. Alaa. Really impressive presentation, and I think it is not only impressive presentation, but also impressive medications that has been recently introduced to the treatment of follicular lymphoma. Actually, as a matter of fact, when we are facing a case with follicular lymphoma in the daily practice, the first thing that is the patient is going to respond, and this is unlikely. And more importantly, what I am going to do when he is relapsed, which is for me sure that he will relapse and will be turn refractory. I think this presentation gives us a very good answer for these two questions. And fortunately, we are have enough time for questions, so the floor is open for a couple of questions. تفضل دكتور ماهر.
Hello. Thank you, Professor Alaa.
ايوه دكتور ماهر ازي حضرتك؟ اتفضل.
الحمد لله بربنا يخليك. Thank you for your intelligent presentation as usual. I'd like to ask about the financial toxicity, as you mentioned. We are in developing country, and we have alternatives which are cheaper. So now all over the world they are speaking about a new term which is financial toxicity.
طبعا. طبعا. I totally agree with you طبعا. That's why we have to consider that in the equation actually. Finance, especially in country like ours, have to be taken in consideration. Hopefully, when we have a full insurance in our country and we have dedicated budget to treat our patients, we can do that for all our patients. Because right now, you can do that only for patients who have a private insurance or patients who can pay out of their pocket. But actually, your point is very well taken, Dr. Maher. أنا مع حضرتك تماما طبعا.
Okay, thank you, Dr. Alaa. And by this, we conclude our session. And please be back in the room at 1 p.m. To continue our this fruitful meeting. Thank you very much.
شكرا. شكرا جزيلا.